concept of eco, the investment which has been recently done, and they were very much impressed by the progress which NIT IRD has specifically made in making use of eco platform for disseminating medical knowledge in various areas. And of all the areas are difficult to treat, TB clinic steals the show because of the sheer number of people who are interested in discussing their TB cases. I welcome all of you. Thank you so much, Apnita. Please go ahead. Thank you. You are not audible. Please unmute yourself.
Thank you so much, sir. Now I request our DDG sir to give his inaugural address. Thank you for joining us, sir. Your presence really encourages us and the others who join this clinic.
And other senior faculty, and all my friends join this. Having to know that learning this clearly and going to come is really good achievement. So I congratulate all the team. There is a lot of effort that is gone in behind. Congratulate all the team. And because one disease which is not easy to diagnose, there are a lot of challenges in medical point, clinical point, even during the management, even after diagnosis. So very happy to know that there is a good support in this and the participants. Already coming.
There's some technical snag, Dr. Joshi. Your voice is not audible very well. There's some technical snag out there.
Even now?
It's better now, yes.
I'm sorry. So I was telling about how this clinic is very, very important. The critical point to clarify the goals and also to bring us together in a platform where we can interact. On behalf of CCD, I'm grateful to all of you, the team at NIT IRD regularly of the last 7 years. Looking forward to this discussion and the hearty welcome to all the faculty who are going to present it. Thank you.
Thank you, sir. Thank you very much. We had some issues hearing you. Maybe your net was slow. Nevertheless, thank you so much, sir. Moving on to today's case presentation, in the current series where the states are being invited in rotation to share a difficult case from their state, we are today inviting state of Uttar Pradesh to present their case. And this will give us all an opportunity to learn from their state, and we'll be able to hear our national expert. Today's session is being presented by Dr. Balamurthy, JR Pulmonary Medicine from MLN Medical College, and he will be presenting the case. He's being supported by Dr. Tariq Mahmood, Head of the Department Pulmonology, and we have Dr. Amitabh Das Shukla, Professor, Department of Pulmonary Medicine from MLN Medical College, Prayagraj, Allahabad, as we know. The state expert is Dr. Rishi Saxena, who's the Deputy State TB Officer from Uttar Pradesh. He has a very keen interest in program activities, and he's also a keen researcher. Then the national expert for the day is Dr. Rajendra Prasad, sir. Sir needs no introduction. He has been a teacher to all of us who are working in the field of tuberculosis. Sir is currently Vice Chair of National Task Force and Director of Medical Education in ERA's Lucknow Medical College. A very warm welcome, sir. And over to Dr. Balamurthy for presenting the case. Dr. Balamurthy.
So first of all, good afternoon to all, to my experts and teachers who are attending this presentation.
Dr. Balamurthy, hold on, You have two gadgets
Devices.
going on together. Please switch off audio of all the devices other than your own device. All the audio should be off. Yeah, you can start now.
Am I audible, ma'am?
Yeah, you're audible still. Audio of one of the devices is on. So you have to put off your.
Ma'am. Am I audible, ma'am?
No, no.
This is some echo, Dr. Bala. There's some echo. Why the echo is there? Just look into the issue.
So please use one device, either your laptop or your mobile, sir.
The audio of all the devices should be off except for the one you are using. Maybe some mobile devices on, so even the audio of the device have to be off. Have you ensured that, Dr. Balamurthy?
Yes, ma'am.
Yeah.
Am I audible, ma'am?
Yeah, no, perfect. Please.
First of all, good afternoon to all teachers and seniors who are attending this presentation. Myself, Dr. Bala from MLNMC. I'm doing my GR junior resident. Let's get into the case. A 32-year-old male, police trainee resident of Mirapur, Prayagraj, come to our department on 15 December 2022 with chief complaints of cough with expectation
Dr.
loss of
Bala, your
eye.
slides.
Share your slides.
Slides.
Yes, ma'am. कहाँ है?
Please share the screen.
Yes, ma'am. Ma'am. Hello. Hello.
We still can't see your screen, Dr. Bala. Just hold on. Yeah. Try again.
Sir, go on share screen option. In front of your screen, sir, you can see a share button, a green button.
Yes.
Yes, sir, you have to click onto that. And after that, you have to open your Power presentation.
Okay.
But it still hasn't been shared, sir. Yes, sir, yes. Sir, open your Power presentation, sir. Open your Power presentation. So once again, just open your Power presentation first, then click on that share.
Yes, sir.
Share button.
Kiss me.
Sir, पहले आप
Dr. Balaji, wait, Balamurthy, we're sharing it from our side. Just give it a second. We will share it. Okay.
Yes. Yes, ma'am. Yes, ma'am.
Can you see this slide now, Dr. Balamurali?
Yes, ma'am.
Okay. Are the slides visible to everybody? Can somebody give us a confirmation? Please raise your hand in case you can see the slides. Yeah, thank you. Thank you for confirming. Dr. Balamurali, you can start your presentation.
Yes, ma'am. 32-year-old police trainee resident of Mirapur, Prayagraj came to our department on 15 December 2022 with complaints of cough with exhaustion, loss of weight, loss of appetite, fever on and off for 3 to 4 years. He has no comorbidities like diabetes, hypertension, is HIV non-reactive, is vitally stable in terms of BP, pulse rate, respiratory rate, O2 are normal. Past ATT history. On 2019, it was started on ATT for TB under based on clinical and radiological findings. System for AB was negative at the time. Treatment for duration regular and inadequate. Patient had to travel frequently for
अच्छा ठीक है वो नेक्स्ट होगा
Dr. Bala, we are not able to hear you.
BP.
I think you have a net issue. Dr. Rishi or Dr. Tariq, would you like to take it over? Dr. Rishi Saxena, sir?
Job
think-
requirements of
No, sir, we are not able to hear you too.
police and his family issue also.
Dr. Rishi, you're not, you're
Uh,
muted.
ATT outcome of drugs in
Yeah, is it Dr. Rishi who's- Dr. Bala, are you speaking or?
no ma'am.
Okay, so do you want to continue with the presentation or do we request Dr. Rishi or Dr. Tariq to present?
बाला की आवाज आ रही है
Dr.
Am
Rishi,
I audible, ma'am?
Yeah, ma'am.
yeah, please see whether Dr. Bala will present or you will take it over. How do you want to go about it? Dr. Bala, Dr. Bala, you can try speaking again. If we are able to hear you, we'll continue with you.
Yeah, ma'am. Ma'am,
Yes,
am I audible?
yeah, you are audible.
Okay, ma'am. Okay, ma'am.
लगे मेरा हमारा पीपीटी नहीं कर पाएंगे अभी नहीं
Sir, PPT is there, sir. With your due permission, because sir, you are having net country issues. Can I be can say this case, sir? Yeah, Dr. Balaji, yeah, Dr. Amtaza Shukla, yeah, Dr. Tariq, sir. Anybody?
sir
Am I audible, sir?
Sir, I'm audible. I'm Dr. Tariq, sir. I'm having presentation, but it's difficult for me to be put on the Zoom link. So I need some assistance to put my presentation, this presentation on the Zoom. Otherwise, I can speak. I can display. I can present on the what you are presenting. I can go through in place of Bala, if you allow. Sir.
Okay. Sir, the presentation is same.
Sir,
No issue, sir.
Tariq sir, do you want us to present and you will be speaking from your end?
Yeah, sure.
Sure, sir. So
So-
then please, we are starting again. You may take over.
Thank you very much, distinguished panelists, and good afternoon. I'm sorry presentation of Bala was not started due to some problem in the net and connection. So starting with the 32-year male police trainee from Allahabad and Mirapur, Prayagraj, came to our department on 15th December 22 with a chief complaint of cough with expectoration for 3.5 year, loss of appetite and weight loss 3.5 years, and fever on and off 4 years, and he's a non-diabetic, HIV negative, and vital parameters fit, normal. This next. On 20th February 19, started ATT for drug sensitivity TB under NTEP based on the clinical radiological findings. The sputum for AFB was negative. The treatment for entire duration was not regular. You are all are audible to me? Hello?
Yes, sir, you are audible, sir.
Okay, thank you. So treatment for entire duration was not regular as stated by the patient and the clinical history of the treating physician. Patient had to travel frequently for this job requirement of police, and that was the COVID pandemic time, and he was training. So yes, next. After 6 months of treatment with drug sensitive TB regimen on 6th of August 2019, patient was found his sputum is smear positive, and that indicates the patient failed on the drug sensitive TB treatment. And on this ground, 19 August 29, CB naught was done and found with rifampicin resistant TB. Next. So the chest X-ray lesion that was present at the beginning, that is on 20th February 19, was little increased in radio density and little increase with the area as shown in the X-ray. That is the 20th February X-ray and the 1st September X-ray. Next. So the past history of the drug-resistant TB started shorter regimen from 2nd September 19 to 27th November 19 for drug-resistant TB under NTEP. And treatment started with this was injection kanamycin, levofloxacin, ethionamide, ethambutol, pyrazinamide, high-dose INH, and clofazimine. On 27th September 2019, second line LPA report come, and that shows the fluoroquinolone resistant and second line injectable sensitive. So from 27th November 19, the shorter regimen was modified and citing fluoroquinolone resistance. So the new regimen that was started is injection kanamycin, ethionamide, pyrazinamide, clofazimine, high-dose moxifloxacin, and ethambutol, and that was started on 27th November 19. Levofloxacin was replaced by high-dose moxifloxacin, and high-dose INH isoniazid was removed from the treatment. Follow-up sputum culture was negative in December 19. Next. So this is the radiological picture. I think this is 29th November 19 X-ray picture. With this X-ray picture, they shows the little radiological improvement. Next. So the patient stopped taking modified shorter regimen for drug-resistant TB himself from 27th February 2020, about 6 months of treatment taken. It was stopped due to job requirement as he was a police trainee and COVID pandemic disruption. From June 2020, patient started taking treatment from private setup at Kanpur. Next. So the X-ray was done again on 29th June 2020, and the lesion more or less same as was the previous X-ray. Next, 23rd June 2020, gene expert was advised at Kanpur, and it gives the rifampicin resistance, and 29th June, 4-drug regimen was started, ethionamide, clofazimine, parazinamide, and ethambutol. All these treatment that he has shown the document or the prescription was mentioned here. After 3 months in September 2020, the tablet ethambutol was stopped and other drug continued till November 2020. After 4 months of treatment, that is December 20, patient developed restlessness, hallucination, aggression, for which he consulted all the psychiatric symptoms that appear in the December 2020. So he consulted a psychiatrist, and there he diagnosed as acute psychosis with depression. So he was advised haloperidol 5 mg, clonazepam 20 mg, propranolol 0.5 mg, tablet olanzapine 10 mg, and fluoxetine 20 mg. At this time, he was also diagnosed with the hypothyroidism, for which he was put on tablet thyroxine 125 microgram. Next. So the chest X-ray PAB was again taken on 19th Jan 2021 because patient was again on and off having symptoms. So a chest X-ray was taken by the treating physician, and this shows that the radiological lesion is a quiescent, or we can say a very little increased than the previous X-ray, which shows a little improvement. So here the lesion is little improved. Next is patient. Yes, next. Patient changed a private practitioner, and he went to Lucknow. Because of the COVID pandemic reason, he was transferred to Lucknow, or he himself consulted at Lucknow because he is not getting the satisfactory relief. This is not clear with his history. So in Lucknow, he consulted to the physician. There it was started HR, Z, and E, all the first line drug, and the sputum status was not, sputum examination was not done there. On 17th March 2021, the ethambutol was withdrawn and HR and Z was continued. Till July 4th, this treatment was continued, and then on 4th July 21, regimen was changed, and the reason for change is not explained. He was started isoniazid, ethambutol, ethionamide, and injection streptomycin. Then on 19th Jan 2022, that is almost after 6 months, all the drugs was stopped and rifampicin and ethambutol was started. On 11th March, again, ethionamide and injection amikacin was added to rifampicin and ethambutol. Then on 18th June 2022, ethambutol was continued, ethionamide was continued, and rifampicin and injection amikacin was stopped, and ofloxacin was added. This regimen continued, and on 28th August 22, ethambutol, ethionamide was continued, clofazimine and injection amikacin was again added, and this continued up to October 2022. Next. Yeah, the chest X-ray that was taken on the 16th March 2021 suggestive of improvement, and the left mid-zone lesion was much improved, and right upper zone was also improved. The fibrosis is present, sign of improvement, radiological improvement is there on the 16th March X-ray. Next. This is again Further, there is a fibrosis and the bronchiectatic changes, post-TB changes were present in the radiological picture, and that X-ray is on 10th March 22. That time, patient was receiving rifampicin, ethambutol, ethionamide, and injection amikacin. Next. This is the follow-up X-ray by the physician, and this is the chest X-ray PFV on 10th June 22. And this time patient was receiving ethambutol, ethionamide, and ofloxacin. Next. In the August 19, the chest X-ray PFU is most likely a quiescent or little bit lesion in the left mid zone, and the right upper zone a little bit raised, we can say, or patient might have a symptoms. That is why the X-ray was taken on 19th August, and that time patient was receiving ethambutol, ethionamide, clofazimine, and injection amikacin. And next. So the treating doctor advised the phenotypic culture and drug susceptibility testing, seeing this X-ray and taking the history of patient, was advised the phenotypic culture and drug susceptibility testing, and the report that comes shows in this list. This is almost all the drug has been, this is all first line drug, and then streptomycin injection, and the second line injectables, and then the fluoroquinolone, Cipro, Levo, Oflox, and Moxi, all present, except the ethionamide. And next. Ethionamide and linezolid. So these drugs were sensitive. So with this patient came to Department of Pulmonary Medicine and Medical College, and with these results that was done from outside lab, private lab, came with the complaint of cough and expectoration, all the cardinal symptoms, came to the department, and patient was started all oral longer regimen, bedaquiline containing regimen, and was replaced with dilamanid and cycloserine, linezolid, and para-amino salicylic acid, along with the pyridoxine that was started in the department. And at the same time, next, and clofazimine was replaced by PAS, because these drugs were earlier used in the past, so this was replaced by the PAS. So we also send the sputum sample for whole genome sequencing, and the report is awaited. Next. This is the chest X-ray peer view of 25th Jan 23, and this X-ray, this X-ray is suggestive of heterogeneous opacity on the right side, with tracheal shift, with fibrotic bands, and some heterogeneous opacity, the most likely due to fibrotic strands and heel lesions. Next. So the treatment strategy that we adopted was linezolid were given because he did not take this drug previously. Moxifloxacin or levofloxacin were not given based on the DST and second line LPA. Moreover, he has also taken high dose of moxifloxacin in the past. Hence, fluoroquinolone were replaced by tablet dilamanid, and tablet bedaquiline was given. Tablet clofazimine was not given because it was already taken previously for more than 2 to 3 months. Hence, it was replaced by PAS. So we wanted to avoid cycloserine, but according to PMDT guidelines, the benefits of using this drug outweighs the potential higher risk of adverse effects. That cycloserine was given, but issue with this drug is that it can cause psychosis and depression, which the patient had past history and has taken the treatment with the psychiatrist that I have already mentioned. Since the patient is already diagnosed case of depression, so we consulted with our institute psychiatrist and he suggested to continue cycloserine with weekly monitoring with suggesting some drugs. Next. Yes, the treatments clonazepam 10 mg, altonil 10 mg, propranolol 10 mg, and trihexyphenidyl anticholinergic 2 milligram. And the patient has been given the modified all oral longer regimen with psychiatric treatment, and he is better and improving with sleep quality and other symptoms till date. At the same time, we also have sent the whole genome sequencing report to come, and we are awaiting the report. Hopefully, very soon will come get the report of whole genome sequencing for any suggested modification according to whole genome sequencing report. Thank you very much, sir.
Thank you very much, sir. Thanks a lot. Thank you for supporting us at the last moment. There were some technical issues, and thank you. You took over. So before we discuss the treatment part, or if we discuss the case with our state and national expert, are there any questions on the history of the patient, the drug history?
I would like to respond, ma'am.
Dr. Saroj?
Yes, there's one question. Vishwanath Pujari, Dr. Vishwanath is asking, how long will continue BDQ and eliminate in this patient? How long we will continue?
That I think we will take with the treatment part. Let's anything on history or any lab diagnosis. You may raise your hands if there are any questions.
Ma'am, I.
Yeah, Dr. Ankur, you have a question? Unmute Dr. Ankur. Yeah, and then we have a question.
Thank you, ma'am. Thank you, ma'am, for this opportunity. My question is, the patient developed psychiatric symptoms, and patient was not having a cycloserine and high dose INH at that time when he developed psychiatric symptoms. So, what can be the reason of psychiatric symptom? Is it some sort of ADR, or it is another issue? So this was my question. Thank you.
Would like to respond.
Yes, sir, please.
Actually, we इसको back करो, इसको back करो. Hello.
Yes, sir.
Hello, Dr. Rishi. Should I?
Yes, sir.
Ma'am,
Sure,
actually, before starting, sir, thank you so much, sir. So before starting the treatment, we have not taken any psychiatric history. Psychiatric history or thyroid test was not done before starting ATT. When the patient started a shorter regimen, DRTB regimen, that time ethionamide was added, and before that, as per history states, there is no investigation of thyroid, no psychiatric opinion was taken. Patient might have the previous history. And number two, that was the COVID pandemic time. Everybody was on stress and the police department and police people who is posted on the field work was on high stress condition, and that too is taking anti-TB drug is not being relieved with the physician to physician and consulting Allahabad to Kanpur to Lucknow. So he might have overstress, and the ethionamide that may be the reason because of that, because of the anxiety and psychological impact due to COVID and all that assembled to cause this problem.
Thank you, sir. Dr. Do you have a question? Dr.
Surendra Prasad.
Yeah, ma'am. Thank you so much, ma'am, and thanks to everybody. So my just one query which is coming is repeatedly looking at both 2019 results and 2020 results. One couldn't see the first line LPA result, and that is very important considering the fact that INHA can tell us about the ethionamide susceptibility. In both the cases, the regimen has included ethionamide, and therefore this is something which was little, a big point of caution and to be considered here. Thank you.
Dr. Rajendra Prasad, sir, and Dr. Jaikishan, I'll just take your question after Dr. Rajendra Prasad, sir. Yeah. Sir, you are muted, sir.
Yes. Now I'm audible,
Yes,
I believe.
sir. Yes, sir.
Thank you for, it was a very interesting case. And to me, it looks what is the ground reality in the field, that we always say that ground reality is something different. But one thing I would like to say, when seeing the X-ray, first X-ray of 2019, it appears the lesion on the left side appears to be new, but lesion on the right side appears to be old, which is still persisting as the same. So there might be some lacuna in the history taking. He might have received treatment even before 2019, which might not have been taken. Usually we see that history taking is a very important step. Sometimes we get this. And later on, we'll discuss other point. But my viewpoint after seeing the X-ray, because in all the X-ray, right side lesion is quite stable, and it appears that even before 2019, he might have done treatment, he might have done X-rays. We don't know about that.
Thank you, sir. Dr. Jaikishan, sir.
Yes, there are 2-3 points here. That one thing that we are blaming the patient that he was irregular. So we should not be blaming the patient, but we should be blaming us that we should have arranged for the flexi dot or patient-friendly dots. So the patient should have been on regular treatment. 1. 2, the patient went to the private practitioners from the public sector. So it means the confidence of the patient in the public sector was not there, or it was not patient friendly. 2, even the public sector person had a regimen which are not up to the mark. So the private practitioner is also not given the training or the know-how on the part of this the PMDT guidelines. So it should be strengthened. We should be training our private practitioners as well on these guidelines. 4, rightly said by the that he is starting the treatment haphazardly. So rather than killing the bug, we are killing the drugs. And now, after seeing the latest X-ray, we are finding that in the right upper zone, the lesion is left middle is more or less clear. So can we think of going for the surgery in this type of the scenario as well? And then another issue here is they have sent the whole genomic assay. So what is the status of the whole genomic sequencing study, whether we will be modifying the regimen accordingly or not, and whether the whole genomic sequencing has been sent in the private lab or in the labs which are undertaking now the validation of the whole genomic sequencing. These are the issues which I wish to say, highlight?
Thank you, sir. Many of the people have joined after our case was presented. So in very short, I'll just summarize the case. It's a 32-year male. He works in police and he was diagnosed as TB, was given drug sensitive treatment for 6 months. Then he was switched over to treatment in 2019 September, where he was given injectable containing shorter drug regimen for about 3 months. And then patient went off to a private practitioner, different private practitioners, and he was given different regime in different combinations of first and second line drugs. And in between, he also had psychosis and depression since 2020, and he's been taking treatment for that. So when he came to NTP back somewhere in November 22, he was already a clinician's nightmare with resistance to all first line drugs, with resistance to quinolone and injectable, and sensitive only to ethionamide and PAS. So right now, patient is with NTP and is being treated on a regime which has been constituted with whatever he is susceptible with. So now I would request Dr. Rishi.
Yeah, madam, am I audible to all of you?
Yes, you are.
Yeah. Madam, this is the case which Dr. Bala Subramanian has presented. Yes, as actually Dr. Tariq Masood has presented. Regarding this case, on the left side are the cases what was the issues which led to these queries which are coming in now. Just a minute. Madam, it's not being shared.
So we can see your screen.
Yeah, ma'am. Just one minute. Madam, regarding past history, on the left side is that the treatment was not regular. And so, though the patient was clinically positive, as diagnosed clinically positive, but the main issue is that, as Sir has rightly said, that there is a fault from our side also, because adherence was not being monitored, which led during the entire duration of treatment. So we don't know what follow-ups were done, and since adherence was not there to treat during the treatment, so we cannot say about the follow-ups. The result was that patient failed on DSTB regimen, because due to non-adherence of treatment, patient went to DSTB treatment failure, as evident is also in the X-rays also. Now these X-rays that you are seeing on February, the opacities on the left middle zone were less as compared to the after 6 months on the right side. On the left side, the opacity became quite dense. So based on the lab reports, when the patient came in 2019, second LPA, it showed a fluoroquinolone resistant. So the levofloxacin was replaced by high dose moxicillin, and the high dose isoniazid was removed. The reason we don't know, but as per the PMT guidelines 2019, this was the regimen: injection kanamycin, levoflox, ETO, ethionamide, high dose H, ciprofloxacin, and that was started. But since second line LPA showed active resistance, so regimen was changed, and due to second line LPA showed active resistance, so the new regimen was injection kanamycin, ETO, Z, and high dose moxifloxacin, clofazimine, and ethionamide. Now, a somewhat bit the X-ray improved, but as Vice NTP has rightly said, that opacity on the right upper zone is precisely there. So there might be issue of previously history not been taken about this. So now patient stopped taking shorter regimen himself without consulting any physician after 6 months of taking treatment. The reason was maybe due to lack of counseling, was not done from our side because of his job, requirement of police job, recruitment, and during the COVID lockdown also. So patient was forced to go in a private sector which also raised his catastrophic cost in June 2020 onwards. Now you are seeing this slide also. On the right side, opacity is persisting, but on the left side, it is somewhat diminishing, and again it is recurring. So replacement sequence started in shorter regimen was done, which would not have been done, as we are told that if there should have been to be replaced, it should be replaced by all oral long regimen. So the drugs were replaced one by one in shorter regimen, and the ADR also started occurring because of ethinomide hypothyroidism occurred, and because of FQ also this started occurring. So what was the need of the hour was the close monitoring of the patient is necessary to ensure that adverse effects of drugs are recognized quickly by the healthcare personnel, which was not being done here. The X-ray, it is showing the percent, the time is going on, but the opacities are there. So when the patient went to a private practitioner, he changed the regimen based on the symptoms of the patient without timely follow-up, without proper counseling. And sir has rightly said that the private practitioner was also not aware of the DRTB management guidelines and what we have to do when the patient of such type of scenarios comes to us, which is a very challenging on our NTEP side. The X-ray on the left-hand side, the middle opacity somewhat diminished, but right side it is still persisting. Same here. This. Now this it was done from a private lab. The DST was done in a private lab. So we are not sure whether that lab was RNCP accredited or not. But it is too late. And patient is almost resistant as per this DST report, and also the X-ray is also showing some bilateral opacities also. See here. No. So now the as soon as possible we should send the sputum culture in NRL and IRL, and patient should be given drugs, although as per the replacement sequence, and also with ADR, and their managing side effects of the ADR also should be done as soon as possible in this case. The query is that regarding WGS. So WGS, since it is based on genetic of a non-Indian patient, specifically from the UK patients, though I'm not aware of it much more, and still India, it is in a research mode at Supra National Lab at Chennai. So we cannot comment on its report. Besides, it is not been taken by our NTP system in India. It is very costly affair at this time. So in a current scenario, we can follow the TMDT guidelines 2021 of replacement sequence, which is as follows. In Group A, on the left-hand side, on the right-hand side, you are seeing the Group A drug, Group B, and Group C drugs. The Group A drugs, Luflox, it cannot be used because F2 resistance was there. Oxyflox, it can be used, but it has been used for the more than 1 month, so it cannot be used. Group B, the Group A, the two drugs remaining are Bedaquiline and Linezolid. Bedaquiline can be used because it has not been used, though it is being still using. Linezolid, it is used, but sensitivity it can also be required for this. So DST is to be done. It can be done at IRL also, and the monitoring of the ADR of both these drugs has to be done simultaneously. Regarding Group B drugs, clofazimine is used and is replaced by PAS, and its DST is also unpredictable. And regarding clofazimine, cycloserine, it cannot be used as patient is already suffering from psychosis with depression. So from Group A, Bedaquiline and Linezolid. From Group B, no drugs are to be used. Now coming to Group C. The Group C, as per the replacement sequence, you are seeing that Delamid, it can be used. Kanamycin, amikacin, it cannot be used, and now we are using our oral long regimen, so there is no need also. And here also amikacin is showing resistance, so no need. Parazinamide also shows resistance, so it cannot be used. Ethinomide, definitely it shows sensitivity as per the DST pattern, and PAS also it is sensitive, so it can be used. But ethinomide shows the resistance, so it cannot be used. So here, group A, you are saying only bedaquiline and linezolid. This has chosen. Group B, no drugs. Group C, as per the sequence, delaminid, ETO, pass. Regarding imipenem solicitinib, it may be used, but as a resort. The reason is that at least 4 to 5 drugs are to be used, and 3 to 4 in the last 12 months. In situations where no replacement of drug is required in the first 6 to 8 months of treatment in MDR or XDR-TB, continuing with at least 3 drugs, depending upon the resistance, tolerability, availability, and contradictions, etc. Combined use of bedaquiline element can be used here when appropriate regimen cannot be come from group A and group B. Here, the duration of bedaquiline can be extended beyond 6 months till the clinical and bacteriological conversion is achieved. And in move, an effective regimen cannot be otherwise designed if 2 or 5 drugs are available from group A and B. So here it is the need of R. Though imipenem cluster is a fourth sequence of drug in WHO guidelines, it will be only used as a last resort for designing the regimen. Operational issues of peripherally inserting central catheter placement for entire duration of its use, need for admission will increase catastrophic cost. Sir, the cost of injection imipenem is around about 1800 and 800 rupees for one injection. It has to be used BD for 6 months continuously. So it comes around 4 lakhs about the cost in 6 months. So it will definitely increase the catastrophic cost. Yeah, one thing is more that BPAL regimen can be used in this regimen, but still in India it is under experimental use. Though KGMC and Agra, they have doing the pilot regimen, as DDG sir has himself went and asked the patient about the history. I was also there. So the last is that from group A, bedaquiline and linezolid, group B, no drugs, group C, delalamid, ETO, pass, and imipenem are can be used. These are the drugs. If possible, sputum samples can be sent to NRL and NTRD for liquid culture of bedaquiline and delalamid to NRL and linezolid to IRL and ethanamide also as soon as possible. And initially, start the regimen as suggested, which can be redesigned after the liquid culture DST report comes. Thank you, madam. Thank you, all of you.
Thank you very much, sir. So we will take any questions before I invite our national expert, Dr. Rajendra Prasad, sir. Dr. Saroj, can you take the questions? And I would also like to thank Dr. Shukla, who's been answering many of the queries regarding the case as he has been dealing with the case. Thank you, Dr. Shukla.
One point I can make, Dr. Neeta, Dr. Jaikishan has mentioned about surgery. I don't think it is one of those cases which should be tackled with surgery, because there are significant lesions. Because mostly we take up cases, we do a CT scan. If we do a CT scan, by this X-ray, I feel there are significant lesions on the left side also present. And while taking up for right upper lobectomy, the lesion suggests that it can very well be crossing the boundaries between upper lobe and middle lobe, or maybe lower lobe also. And we may end up doing a pneumonectomy. So this patient with his general condition, BMI being poor, and this irregular history is not a good candidate to be offered surgery for drug resistant.
Thank you so much, sir. I was just planning to take this question with you. So thank you for answering. Dr. Tariq, you want to add something, sir? So you're muted, Dr. Tariq.
Okay. Thank you, ma'am. I must compliment Dr. Rishi. He's presented well and with suggestions what are the lacunas and what is the solution according to guideline treatment. But I wanted to make a comment that this patient was from the very beginning was not counseled regarding the adherence, regarding the completion, regarding the seriousness of the disease and the adherence to the treatment and the doses of the treatment, because many times we found that the 70 kg patient, 5-weight band patient, and he used to take 5 tablets of DOT initially. What I felt that because of the irregular treatment, because of the might have irregular doses, might have not taken as a single oral dose in a divided dose, may acquired the resistant tuberculosis MDR and then followed by XDR-TB. And mostly this is because the treating doctor was not following the guideline, and he is not suggesting accordingly to the patient. And one question to Dr. Rishi, please, the authenticity of the whole genome sequencing, and if we don't have option for, as imipenem, cilastatin and meropenem is very costly, and we can't afford to a patient in general this particular drug. Is there any chance of adding the coamoxiclav in it that was there in the previous line?
Sir, regarding this question, sir, you have already said the right question, because this is a concern for everybody also. Because sir, a patient also came from another patient was there, and we tried to procure it from the from private sector also, but there were very issues. The drug is very costly regarding imipenem, cilastatin, penem. And besides this, sir, we don't have any adequate data for it. Yeah, any adequate literature for it, so that we can see what are the side effects of this drug if it is used being continuously, apart from increasing catastrophic cost. We don't know the side effects. But what we have said, the BPAL regimen can be an alternative for this patient. I don't know much about it, to be very frank. We will ask here the national experts will be had to answer these questions. But regarding the rest part, it's definitely there. That as in the current scenario, what are the resistance here, and what we can give as per the guidelines, which I have mentioned here. Now, it's up to sir, the national consultants who can answer your question very most effectively regarding imipenem and WGS, sir. Thank you.
So before we go to the difficult part, there are some questions. Dr. Saroj, can you take this?
Yes, ma'am. Dr. Manoj from Sitamarhi, Bihar, is asking that is there any replacement? Why we have replaced a drug in shorter MDR regimen? And acute resistance was found, was replaced with the high dose moxie.
Madam, the replacement was being done by a private practitioner. So he did what as per the symptoms of was there. He was totally unaware of the guidelines of this. So he did what the patient said. Okay, you leave this drug, you give this drug. What he had knowledge of the drugs, he was giving indiscriminately use, and these are the issues. This is the main drawback in the NTP, which we are trying to focus on it, that private doctors should be sensitized when such patients come here.
Yes, sir. Rightly said. There's another question from Dr. Alka.
Regarding change regimen, Dr. Singla wants to add.
Yeah,
yes, sir.
Yeah. It should be very clear that in a shorter regimen, whenever there is a FQ resistance, shorter regimen has to be stopped, and we have to start the oral longer regimen. So that should have, rather than just replacing levofloxacin with high dose moxifloxacin, so that was not the correct choice at all. So the shorter regimen should have been stopped, and the longer regimen should have been started. Thank you.
Thank you. There is one more question from Dr. Alka regarding videoculin extension, circumcision which will extend videoculin duration.
Madam, here since the we have no options left from A and B group drugs, so from group A we have only linezolid and bedaquiline, and then no options from B. So we can delamide, depending still. Both the drugs can be used till it is also mentioned in the guidelines 2021 that it can be used till the clinical and the radiological patient is clinically improved. We can give till that time. Yeah, till that time we can use bedaquiline and delamide, madam. There is no issue. This just can be given. Both of these drugs can be given, madam.
Thank you, sir.
Sir, you want to? Yeah, I think.
Yes, no, the rest of the question have been taken care of Dr. Shukla, the chat itself. Yeah.
Thank you. Sir, now we invite our national expert for the day, Dr. Rajendra Prasad, sir, for his comments.
Thank you, madam, for inviting me. I was listening from very beginning. Some of the issues which I wanted to raise, which I'm raising for last so many years.
Sir,
You can see by
sir,
this case, the good point of this case is ultimately to me as an expert for last. मेरी आवाज आ रही है?
Yes,
Am
sir.
I audible?
Yes, sir.
RS.
There is some internet problem from very beginning, I think, from every corner. So what I'm trying to say, ultimately what happened that this, if I see the last X-ray, the left side lesion has drastically reduced. As I said earlier also, right side lesion, there will be hardly any change because it, to me, it appears an old lesion. So he appears to be whatever drugs, all oral longer regimen with some modification, he appears to be responding. I do not know what is his clinical situation, whether he is also responding clinically or not. That was not clear to me. So that was the good point that whatever treatment we have made ultimately, and he appears to be responding radiologically. And such type of cases to me should be followed by frequent cultures. But that is the only thing which can decide about whether he is really responding or not. Because molecular diagnostics in a follow-up situation is very, very difficult to get any help. That is another issue I want to raise. But let me say, start from beginning. When they said in the case presentation, this was a DSTB as per NTEP. How it was a DSTB when Rifampy, when Gene Expert was not done? 2019 Gene Expert was available. So we are not following the universal DHC because this treatment, I believe, was started from the government before the private sector, after the private sector. So all the ground reality is the thing that things are not being followed in letter and spirit what guidelines tell. Second thing I would like to raise that has already been raised by somebody. Shorter regimen is a package. There is no, as Dr. Rupak Singla said very rightly, it's a package. There is no question of replacing. At that time also, he has been shifted to the all oral longer regimen with some modification. And you know, this patient, as Dr. Jackson has very rightly said, that there is just some lack of confidence, or we are not able to generate. So the person is moving from private to government to private, and from private different. I have heard that he has also received treatment in Kanpur. He has also received treatment in Lucknow even. And the treatment you can see, the difference of those doctors who in the private sector treated, that has a very good implication. I think Rishabh is here as a representing as STO and Deputy STO. We are educating our government sector doctors, but we are hardly educating our private sector doctors. You know, here I would like to say that companies have stopped doing any CME in tuberculosis, literally stopped. Now it is the duty of the government and duty of the teachers, respective STOs and other people are sitting, medical college professors are sitting. This is our duty to train our private sector, because through this case, you can see the private sector doesn't know about these new guidelines, whatever is there. So my suggestion at this stage would be that the education to the private sector must be, if Dr. Joshi is listening at the central level, then it must go to him that there must be some program in the thing. I know that program is there, but that has to be strengthened, especially for education to the private sector. The last question about this surgery, well, what Dr. Diwan has said, I partly agree with him. But if you see the CT scan, last X-ray has shown probably lesion on left side has literally disappeared. Very small lesion is persisting on left side. And then the right side lesion, I have already said, I will repeat, this is an old lesion. There will be hardly any change in that lesion. So surgery, after doing CT, after doing say culture, because he appears to be a difficult case. There is a problem of drug resistance. Whatever DST we have, that shows literally drug resistance to every drug, except 2 drugs. And how reliable is that DST? I always take lecture for last 20-25 years that these labs, labs cannot be godfather. Labs cannot be 100% reliable. Many times we get a wrong report from different labs. So what I'm trying to ultimately the clinical condition of the patient, radiology of the patient, and in such cases, I think culture for follow-up, culture is a good method to see if suppose he has become culture negative at this stage and he has reduced radiologically. Clinically, I do not know how he is reacting. He must be responding if he has. So surgery can be, remotely surgery can be, because he is the case who is likely to relapse because he has misused these drugs. In between, he has misused a lot of anti-tubercular drug, first line, second line. So there are surgery could be, because he's a young man, and so surgery could have a very remote chance to get. We need a surgeon like Dr. Diwan to really evaluate this case even for surgery. So these were some points, and in the end I say, the ground reality is different. You may sit in the air-conditioned room in our offices, we may say, but I as a clinician practicing in tuberculosis for last more than 4 decades, reality, what we have to do, I would suggest Joshi ji as at the central level and Rishi Saxena at the state levels, because this case belongs to Uttar Pradesh, that we need a lot of work on the ground, and so that the management of tuberculosis improves. इसमें बेचारे की मरीज की क्या गलती? What is the fault of the patient? In between, COVID has also come. He's a police person. He's a very important person for us, for the society. So naturally, we have to improve a lot so that our treatment regimens have changed. I always say, let me repeat here, we have acquired all the treatment, all the newer diagnostics. But at the level of implementation, there are certain deficiencies that it is our duty of everyone. I think many of the STOs, many of the person who concerned about tuberculosis. I'm also concerned about tuberculosis. Being a teacher, we should improve the ground reality. We should improve the implementation of the program. And in that last word, I say, education of the private doctors is very essential. As you know that literally about 40 to 50% of the cases, in this case also, he has visited many private practitioners even in Lucknow and in Kanpur and many other places in Allahabad. So that education is very essential. Thank you very much, Neeta, for once again giving me this opportunity as a national expert. I talked about the general thing. As for gene sequencing, as somebody has raised, gene sequencing is a coming up investigation. There are 1 or 2 private labs who are doing it. We are also getting it done. But I have taught MBBS students for last more than 45 years that don't be dictated by any investigation. Take everything together. And then you find that if it is fitting to you, not that I have seen cases where there's a gene expert is saying this, but there is no tuberculosis. So what I'm trying to say, I will repeat here. मैंने बहुत लोगों को पढ़ाया हुआ है, जितने लोग यहाँ बैठे हुए हैं, लेकिन ये कि मैं हमेशा पढ़ाता रहा हूँ कि भाई जो गोल्ड, if we can, so all the investigation you have to take together We have to see the patient condition. We have to do everything and then decide your management. So gene expert may not be very, gene sequencing may not be panacea already. You know, culture sensitivity is the gold standard. DST is still gold standard. So that is, yes, you may take some help of the gene sequencing, but still I think country has to adopt at the national level about the fate of the gene sequencing. But till that time, to me, good point to me is patient to me appears to be responding. I would like to ask A.D. Sukla, who is treating this patient, what is his clinical condition? Nobody has touched that. A.D. Sukla, sun rahe ho meri baat?
Dr. Amitabh Das Shukla.
Amitabh Das Shukla, since he is treating,
yes,
what I am told, he is a treating physician. तो इसकी कंडीशन क्या है क्लिनिकल, वो कहीं बताया नहीं है.
सर प्रणाम सर आपको.
प्रणाम
सर. ये पेशेंट जो है ये इम्प्रूव कर रहा है.
हाँ.
इसको हम लोगों ने दिसंबर लास्ट वीक से ऑल ओवर लॉन्गर रेजिमेन थोड़ा सा मॉडिफाई करके हमने दिया है.
वो तो
और
ठीक है.
ये 2 महीने सर इसको हो चुके हैं, जिसमें कि एक एक्सरे हम लोगों ने 1 महीने बाद जो एक्सरे कराया था उसमें एक मार्जिनल इंप्रूवमेंट सर दिख रहा है. और अभी जो पेशेंट पिछले हफ्ते फॉलोअप में आया था, तो क्लिनिकली भी सर ये इम्प्रूव किया है. ही हैज गेन्ड अराउंड 1.5 kg वेट आल्सो. और इसका जो साइकेट्रिक सिम्टम है वो भी कंट्रोल में है. वी हैव कंसल्टेड साइकेट्रिस्ट आल्सो.
That's very good. That was my anticipation also by seeing the X-rays and other thing. एक इसका CT भी करा लेना चाहिए अगर सर्जिकल इवैल्यूएशन कराना है इसे अच्छे से. Otherwise follow it. I think next follow up should be by culture. You should do cultures as per rule. क्योंकि अब molecular diagnostics से इसका follow up होना बड़ा मुश्किल है इस केस का.
Yes, sir.
Thank you Neeta, and thank you Rupak for giving me this opportunity to share some of our thoughts which we are sharing as teacher for last more than 4 decades. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir. You are a big support to us, Dr. Rajendra Prasad, sir. सर हम लोग जब बहुत बड़ी बड़ी बातें करने लग जाते हैं तो आप हमें वापस खींच के बेसिक्स पे ले आते हैं. एंड यू रिमाइंड अस ऑफ दैट ऑलवेज. मतलब हमें बहुत आपसे सीखने मिलता है. थैंक यू सो मच सर. Dr. Ashwini Khanna, who's also the consultant to Delhi government and has been a state TB officer, he wants to ask a question or make a comment. Dr. Ashwini.
I just want to make a comment based on what the patient has taken the treatment so far. I think at the moment the patient the best regimen, and in the given circumstances, bedaquiline, delamanid, and linezolid, 3 important drugs. But what we must make sure is, I think the sputum sample must have been sent sometime in December or January. So we have to look at the sensitivity pattern, because the earlier reports, what were reports are from a private lab, which is unreliable. Now we must have the reports which should be available from the IRL and take a call after that. That's all I want to add. You must follow up with a DST.
Thank you, Dr. Ashwini. Now to before I wind up, yes, sir, Dr. Rishi.
Yeah, madam. जैसे sir, vice executive chair has rightly said, there are issues with the private sector when the patient comes here and they go for treatment with them, and they have very limited knowledge of TB. Exactly. In fact, many chest physicians are very much less aware of this NTB guidelines also. So what we are doing, sir, in UP we are trying to, we have a CME also from the our government side, where DTO in his districts call all the private practitioners, signed by the DM letter regarding date, time and place in consult, and we also called a faculty of the same districts or from the nearby districts also. He can come here. All the WHO consultants, we have 18 WHO consultants in UP also. So they're all there, and any faculty from the nearby medical college, Department of Respiratory Medicine, they can come, and if they train, the main, our focus is that when a patient comes to them, how they can diagnose it with the our scenario, our the NTB program, with the free, also bearing the catastrophic cost in the mind, definitely. And this is already being going on, but it is not up to that mark as we are expecting to end TB by 2025, sir. Thank you.
Thank you, Dr. Rishi. At least in this front, you have to improve.
Sir.
That was my message.
Thank you, sir. So before I wind up, I will request Dr. Rupak Singla to please give us the crisp summary. What are the take-home messages from this case?
Okay, thank you, Ropnita. As has been discussed also, whenever we are starting a patient on treatment, the pre-treatment evaluation is must. Like in this case, we do not even know whether this patient had baseline psychiatric symptoms or not. So in all these cases, diabetes, HIV, underlying liver disease, kidney disease, psychiatric symptoms in females who have to rule out pregnancy, all these things are very, very important and they should be done routinely. Then adherence is very, very important. We don't counsel the patient properly. We do not ensure that patient is adhering to the treatment. And that is one of the biggest reasons that the patient, they stop taking treatment, and even management of the adverse drug reaction, which are very common with these drugs. So unless they are managed well and patient is counseled properly, they will not be able to ensure the adherence to the treatment. And as we already discussed about the shorter regimen, we should know when to give, when not to give, and when to shift from shorter to longer. So there are clear guidelines on this issue, that when we should give and when we should not give from the beginning. And during treatment, if something happens, especially like FQ resistance comes up, which was not available earlier, we should shift to the all over longer regimen. And you see, proper regimen, whenever we are going for a new regimen, at least 3 or preferably 4 new drugs should be added. So this we forget and we keep on adding 1 or 2 new drugs, and we find patient becomes resistant to the new drug which has been added also. And in the process, what happens? We keep on losing the drugs. So that to avoid that, at least we should have 4 drugs added to which patient is likely to be sensitive, to which patient is likely to be responding. So this basic principle we have to ensure. Like in this case, if you talk about the regimen, the bedaquiline, linezolid, delamorate, they had not been used earlier. So they are the good drugs. Ethonamide, I think, will not be, although the lab is saying it is sensitive, but it has been used multiple times in this case, in this patient in the past. So even if the laboratory says it is sensitive, it will not be a very good drug. So that may not be used. The PAS, yes, it has not been used, and even the laboratory is saying that PAS is sensitive if it is available. There are availability issues. So PAS can be used in this case. Regarding cycloserine, yes, cycloserine is advantageous. It is a group B drug, and it's likely to be effective. It has not been used earlier, but the disadvantage could be that patient is having the psychosis and depression. So as it has been done by the team who are managing the case, that keep the psychiatrists in the loop. And whenever you find patient is deteriorating, you must act immediately. Otherwise, sometimes we have seen even suicidal tendencies are there. So that must be prevented. But whenever we are using antipsychotic drugs, like in this case, we were told patient is on haloperidol, clonazepam, patient is on fluoxetine. So bedaquiline has got interaction with these drugs in the form of prolongation of QTC. So even that we have to keep in mind, that better to use the drugs which do not cause prolongation of the QTC if possible. So that also we need to keep in mind. Another very important drug which could have been used in this case, if you see there are many ifs, that is imipenem cilastatin. At our institute, we have had a good experience of using this. More than 70-80 patients we have used imipenem cilastatin, and with very good results, especially in these cases where we are cornered, where we do not have sufficient number of the good second-line drugs to make a regimen. So, but disadvantage is the cost, almost 1,000 rupees in the morning, 1,000 rupees in the evening for about 6 months or sometimes even more. There is a requirement of inserting a PICC line that we insert. We have to insert a peripheral inserted central catheter. Otherwise, we cannot give, because it requires infusion to be given. 1 hour infusion in the morning, 1 hour infusion in the evening. So that cannot be done with the help of cannulas. They get frequently blocked. So if PICC line is there, then sometimes we have seen it last about 6, 7, 8 months. So that can be, in case we are able to arrange for this patient, this could be a good addition. Because in case we lose this regimen, we have nothing to offer to the patient. We have used bedaquiline, we have used delamorate, we have used linezolid, everything. So in case we are able to add imipenem cilastatin, it will be a very effective regimen for the patient, but we should also know the limitations of using this imipinam cilastatin. And but in children, please remember that it can cause convulsions. So in children, if we are choosing the imipinam cilastatin, then meropenem is a better drug. So there we should use meropenem rather than the imipinam. So that should also be kept in mind. So these are the primary things which we need to keep in mind when we are treating these drug-resistant cases. And last but not the least, as Dr. Rajendra Prasad has emphasized, very, very important to educate our colleagues in the private sector. They have not used the new drugs. They are not aware about the proper regimens to be used, and this can lead to the development of resistance to the newer drugs and the other drugs also. So it is very important to educate our colleagues in the private sector. Thank you. Thank you very much.
Thank you, Dr. Singla. A last comment from Dr. Tariq. He has raised his hand. So you want to add anything? Okay, so then we come to end of this session, and we have Dr. Ashok Bharadwaj, sir. Sir is chairman of National Task Force. Sir, I request you to propose vote of thanks. Dr. Ashok Bharadwaj, sir.
Could not join in the morning because I was taking a session in district. So I echo whatever was told by Dr. Rajendra Prasad. So Anita, I have visited many colleges in the north as well as in the south. Almost I can say 50% of the medical colleges, the guidelines are not being followed. This is more than 50% medical colleges. The PMDT guidelines are not followed in principle. This is a bold statement from my side. If in some of the medical college, people are putting the DRTV treatment without even DST test, without even doing another test. So this is the state of affair. So in most of the medical colleges, they don't have any DRTV committees. So whatever I could see that they are not differentiating between the core committee of the medical college and the DRTV committee of the medical college. So we have to follow the guidelines. It is not one's personal view to treat a patient or to follow the patient. We have to go as per the guidelines issued by Government of India, and we are following PMDT guideline 2021, and it has to be followed in principle. So I will request all medical colleges, please work in this direction. And I echo Dr. Rupak Singla also, because the chest physician in medical college, they have the greater credibility, and then they can sensitize, they can undertake CMEs with all the private practitioners in their vicinity, so that these practitioners also follow the same guidelines what we are following in the public sector. So I have to say only this thing, because we have to follow the guidelines if we have to move toward the ending TB from our country. Thank you very much. Thank you, Singla, for giving me a chance. Thank you.
Thank you, sir. With this, we come to the end of our clinic, and we thank everybody who has joined us, especially team from Uttar Pradesh, Dr. Bala, Dr. Tariq sir, Dr. Shukla, Dr. Rajendra Prasad sir, and all the others who have been who are participants of our clinic. And I would also like to thank Dr. Divan sir, who has constantly motivated us and encouraged us to carry on these clinics. Thank you. Thank you, everybody.
Thank you.
There's a poll on your screens. Please answer the poll. It is very important for us to have the feedback from you. Thank you.
Thank you.
The link is on the chat. The feedback link is on your chat. Please click the link and give us the feedback. Thank you so much.